Okay, so we'll make a start there. So yeah, big welcome to everybody joining our webinar today. Thank you very much for joining us. We've got an exciting lineup ahead. So today we're giving a talk on World Cancer Day and the theme of closing the care gap. So we've got a few things lined up to talk about that, what the University of Manchester is doing to work towards this aim of closing the care gap. And it's great to see so many of you joining us today. We've also got a stream on our LinkedIn account. So there's people joining from there, from all parts of the world. So that's great to see. Please feel free to send in a message about where you're joining us from today. Maybe tell us a little bit about yourself, like the industry that you work in, or the field of study that you're interested in. And also feel free to ask any questions throughout the webinar. We've got a Q&A function on the Zoom, and you can also drop a message on the LinkedIn stream or in the chat box. And we'll try to answer those questions. If we don't get time to get through them all, you can feel free to email me at studyonline@manchester.ac.uk. I'll give all that information at the end as well. So if you have any other questions that we don't manage to get to, I'll email you with some information regarding that. So I'm joined here by an exciting panel of people. So we've got Dr. Suzanne Johnson, who is our program director for the Transformative Oncology online course. So she'll be talking to you today a little bit about that and some of the research that she's been working on. We've also got Dr. Cleona Kerwin, who is the Unit 8 lead for that program. So that's great that Cleona's joined us today as well. And we're also got Mike Thorpe and Imogen Westwood, who are heavily involved in patient advocacy work around the UK. So thank you very much that they could join us. So before we get into the content of the webinar, maybe our panelists would like to introduce themselves a little bit. Maybe Suze, you'd like to start first.
Thanks, James. Hi to everybody. Thank you for joining us, and for those who are catching up later as well. So as James said, I'm Suzanne Johnson. I'm the Programme Director for Transformative Oncology, which is our new online master's degree, and I'm delighted to share this webinar today with some fantastic people on the panel. I'm really looking forward to a good conversation, so thank you. I'll pass over to Professor Cleona Kerwin.
Hi, I'm Cleona Kerwin. I am by clinical trade a oncoplastic breast surgeon. So that means I do breast cancer surgery, run breast cancer clinics, and I also do reconstructive surgery as well for breast cancer patients. From a academic point of view, I am Professor of Surgical Trials, doing surgical trials in cancer and other disciplines, and I do an awful lot of breast cancer trials, looking at the role of different types of radiotherapy, drug treatments, different surgical devices for breast cancer, so quite a wide mix. And I also run a lab doing basic science and translational research, looking at the interaction of the clotting system and cancer. And I'm really passionate about delivering the best care for all of my patients. And so I think this whole course is incredibly exciting. Thank you.
Maybe John or Imogen would like to go next.
Yeah, I'll go for it. So I'm Imi. When I was 13, I was diagnosed with primary bone cancer. Just last month, I hit 8 years in remission. I'm now at the University of Manchester doing my master's degree in healthcare ethics and law, hoping to qualify into law rather than medicine. I now work at Bone Cancer Research Trust as a virtual fundraising officer, and in my spare time I'm a patient advocate for kind of several small cancer charities around the country.
John, would you like to go next?
Mike.
Oh, Mike, sorry, Mike, sorry.
I'm Mike Thorpe. I was diagnosed with prostate cancer in 2014, and since then I've become involved in patient involvement with Greater Manchester Cancer, which is the cancer alliance that deals with cancer treatment across Greater Manchester, and I also work with the cancer programme NHS England, as well as various other organisations, universities and charities. So keeps me busy.
Great, thank you very much, Mike. So yeah, that's our panelists today, and our webinar will follow this format today. So in part one, we're going to talk a little bit about how the University of Manchester is helping to close the cancer care gap. And then part two, we'll talk a little bit more about the importance of the patient voice to effective cancer research and care. And then part three, we'll talk a little bit about the Transformative Oncology programme at the University of Manchester. So, Suze, would you like to share with us how the University of Manchester is working towards closing the cancer care gap?
Yeah, very happy to. Thanks, James. And thank you again to the panelists who joined me here today. I think to start with, what would be useful is to really sort of describe what we mean by equity in cancer care, which is what we're hoping to achieve ultimately. And this is about the fact that every person really is entitled to the services and education that's needed to take the steps to prevent cancer, to detect cancer at the earliest possible stage, to receive the appropriate treatment for their cancer, and also to benefit from quality aftercare following that treatment. But to achieve this equity, it really requires a full systemic approach. There are essential steps to ensure that everybody feels valued and included. And this means really addressing social determinants of health. So these are non-medical factors which influence health outcomes, which include things like food insecurity, basic access to basic amenities or social inclusion, and also looking at ways to address avoidable inequalities which may come about because of either historical or even contemporary injustices. For this approach to be effective and to provide what's needed, which is a really sustained and long-term improvement, it really requires effective engagement with all of the relevant stakeholders. So this is why this webinar today is really important for me. So the relevant stakeholders include everybody from patients and caregivers through to clinicians and the allied healthcare professionals, and also the advocates. Listening, and I can speak from experience in research as well, listening to patient insights and having that insight into their lived experience can really provide such an essential understanding of the experience of living with a health condition such as cancer. And importantly, it can help healthcare professionals, scientists, educators to shape their practice to be more considerate, more inclusive, and more empathic. So, as James mentioned, we've had some success in recent years with some projects here in the University of Manchester in terms of directly improving outcomes for patients with cancer by actively seeking ways to close that care gap through patient consultation in a number of different ways, but also bring in some innovation to the way that we approach cancer screening, for example. So bring in cancer screening to the communities who would ordinarily be less inclined to engage with some of those health services. So on the slide at the moment, you can see some examples of the research that's been happening here in Manchester. I would direct anyone to the Manchester Cancer Research Centre website for further information, and we'll make sure that there's a link in the chat for you for that. The big headlines really are describing projects such as the lung healthcare check, where vans were established in supermarket car parks across the north of Manchester initially. And they were there really to invite shoppers in for a free lung health check. This approach alone saw an unprecedented increase in detection of lung cancers, which otherwise perhaps would have gone undetected. So detecting those cancers much earlier on. Another project is around new urine tests which are being developed for HPV, and these are tests which can be performed at home. So this again is looking to remove certain barriers that people feel to help seeking, and this is aimed at detecting cervical cancers. And there are other projects as well which target specific communities where there is growing evidence of disparity of engagement with cancer services. And those projects work directly with communities to And a key word with this is co-develop, to co-develop resources and then increase opportunities to take part in research, which then aims to start addressing these gaps. And as I say, you can find out a lot more about all of these individual projects on the Manchester Cancer Research website, or indeed on the University of Manchester within the Division of Cancer Sciences website. So I suppose, speaking as the Programme Director for Transformative Oncology, it's been a pleasure really to be able to have access to and work with these stellar academics and researchers, you know, who are world leading in their field and award winning. And what it means for our students is that we're able to encourage those stellar researchers to contribute to our learning materials, so the students are able to learn directly from their experiences. It's really one thing that makes our master's degree really unique is its progressive curriculum. And it's really designed to make sure that, you know, anybody who wants to work within the field of oncology and wants to make a real difference in the outcome to patients, that they get they're able to develop the skills that they need. So that might be establishing new screening initiatives in their home countries, maybe looking to develop biobanks or new research into biomarkers, or improving cancer care through more empathic innovation. Again, further details can be found about the programme, and follow the links provided that we've included in the webinar. But I think that's probably enough from me for now, because I really want to talk to our guests here. So James.
That's great. Thanks very much, Suze. It's yeah, there's lots of fascinating work going on in Manchester right now in this field. So yeah, feel free to look into these articles and studies a little bit more. You'll find that at the MCRC website, just linked at the bottom there. So yeah, thank you, Suze. So we'll move on to the next part of our webinar. So that's where we open up to a few more questions with our panelists, and I think Suze will ask some questions to Mike and Imogen. And also our audience, feel free to use the Q&A function if you'd like to ask some of your own questions. But yeah, we'll start with the questions from Suze.
Great, thanks, James. Okay, so I guess just reflecting on some of the things that I was just talking about then, if you were to think about something which is, you know, really important, why do you think it's really important to listen to the lived experiences of patients who have lived through their cancer treatments, and how do you think that can help to close the cancer care gap? And I think maybe, shall I come to Mike first?
Yeah, with cancer, the treatment is usually extremely complex in that you can have various types of treatment, radiotherapy, surgery, chemotherapy. Your experience of going through that can be absolutely bewildering. To get a cancer diagnosis itself, you completely go into a world you've never thought you'd ever be in. Everything's new, everything's scary, and you're confronted with this array of treatments, and you need the patient voice of people who've been through it before, because as you're going through your diagnosis, you don't know what you don't know, because every day is a new experience. So it's the likes of Imogen and myself, once you've been there. I mean, particularly someone like Imogen, in that as she had a childhood cancer, she can look back now and see what, not necessarily she needed to know, but what needed to be done, what would be important to her. The big question is, every clinician should be asking, and it's a different answer every time, is what is important to you? Because we've all got different priorities. You may be married with kids, you might be a single bloke who don't care and sort of like, I don't want the treatment, I'll just get on with it, or how things will affect you. So it's vital to have that patient voice and to listen to it. Sometimes you get clinicians who, with the best will in the world, think they know better and insist on treating you because this will increase your life, but it might not be the right quality. Quality might be your priority, and it's a matter of sort of like having that informed decision.
That's absolutely true. And you know, one of the ethos of the program actually is we really focus on the fact that every cancer is individual, every patient is individual. So you know, doing it on a case-by-case basis is really important. And you're right, gathering that information, that first-hand knowledge and that first-hand experience must be so much more informative to a patient who's faced with those choices of, you know, the complex chemotherapy and what impacts that might have. Thank you, Mike. Imogen, do you want to add something?
Pretty much just echoing what Mike said, but for me, as you know, I can obviously only speak from kind of legal academia, but I'm very aware that you can get caught up in the kind of possibilities and the theoreticals, and sometimes you kind of fail to just see the reality of what's going on. And I think that's the importance of listening to lived experiences, is you're making sure that the first class care that you're so, you know, dedicated to and so determined to provide is actually the first class care that people want and that people need, because sometimes there's a bit of a disconnect between what we think we're giving and what we actually are giving out into the world. And just as Mike said, I think there's a tendency in the kind of research world to focus on efficacy of treatments. And you know, I've known people who, you know, say like they're a swimmer and all they want to do is to be able to continue swimming, and so you know, a limb salvage might not be the most, you know, best treatment objectively, but for them it is. And if that is never given as an option, then you know, there's kind of a disconnect there. So you need to make sure that the treatment and the opportunities are for the person and not just for the patient that you see in front of you.
Absolutely. And I guess having a balanced view from other people who've gone through that decision-making process, because it is a process, isn't it? It's not something you can just decide on straight away. You have to take an awful lot of factors into account. I think it must be an incredibly valuable thing. I might jump over to the clinician on our call actually to give you an opportunity to chip into this part of the question. And so Cleona, you know, as a clinical academic, but also as a breast surgeon, do you have many opportunities to engage in and learn from patients or caregivers, either inside or, you know, your clinic or in your research activities?
Absolutely. And every day is a school day. And you are constantly learning, and what you learn from your one patient, you apply to other patients. I mean, I think what Mike was touching on there was that sense of loss of control when you enter down the cancer pathway as a patient. And I think it's our job as clinicians to try and give patients back that control and say, these are the options, these are the pros and cons of those options. So exactly, again, as Imogen said, you know, it's about efficacy versus your personal priorities. So just for example, taking breast cancer as an example, one of the very sort of complex conversations I might be having with a patient would be that you need a mastectomy, you need your breast removed, but should you have reconstruction? Do you want to have reconstruction? And what are the pros and cons of having reconstruction? So it may potentially delay you going on to chemotherapy. So it may be a bit negative in terms of cancer survival if it impacts on you getting your chemotherapy. But it may be that cosmesis and how you look is your absolute biggest priority. And so for your ongoing quality of life, it's very important. But actually, maybe your priority is function, like Emmy said about the swimmer. So actually, you don't want to have your anatomy fiddled with. And so therefore, you want to be flat because it's quick and easy and you get back to your sport. So for example, I did a bilateral mastectomy on a young, fit, healthy woman, and she wanted to go flat because she wanted to get back to normal function quickly. And then she came back to the clinic saying, it is amazing, I can wear a rucksack without boobs getting in the way, which is something that would never have crossed my mind and is a really important learning point. So now we're doing research studies of trying to find out the time you recover with the various options of surgery, so that we can help give patients much more precise information about the pros and cons of the different surgical options, so that they make that informed choice that's right for them and their personal priorities.
And I guess keeping in touch with patients also to, monitor and help to gather that additional information as they're recovering, or how long it takes, etc. It all feeds into that research, doesn't it? It all feeds into that decision making for the clinician. Fantastic, thank you for that. So I guess so we've got some understanding of why the patient voice is really important. So maybe coming back to our patient advocates now, what sort of activities and what sort of projects have you been involved with so far where you've really felt that you've managed to sort of have a bit of an impact, and you're looking at ways to really close that care gap? Maybe I'll come to Imi first this time.
Such a fiddle doing all the mute and everything. So I'm mostly on like a kind of small scale. So I started out kind of just as a volunteer with Bone Cancer Research Trust, and only in the past kind of year or so have I really kind of took the advocate role kind of under my wing, because I've become increasingly aware that as a young person speaking out, I have a different perspective, and it kind of hits a bit harder in some cases, because hearing it from a young person, it makes people think twice sometimes. So some of the things that I've been doing is going to universities. So I did my undergrad at the University of Nottingham, and I go and talk to the undergrad students there for cancer sciences to talk to them about the opportunities of research that are out there, kind of help them to understand the patient perspective. And my kind of talks focus on as well, not just the kind of narrative of, from diagnosis to late effects, but also the kind of holistic view of it, of, how it affected relationships, how it's affected, my whole life, and how you need to not just look at it as a solution to fix, that you need to kind of look at the whole spectrum. On that note, I've also talked to the Bone Cancer Research Trust's North Conference back in 2019, where I did a similar talk about the impact on my mental health of my treatment, and the kind of lack of any kind of mental health aids at that point, and also the fact that fertility was not mentioned to me at all in my treatment, because I was 13 at the time, and then come when I was 16, 17, I found out, and I shouldn't have found out off the internet or a conference. I should have found out from my doctor. And so that's a kind of inequality that I like to talk about and make people aware of. And then kind of lesser things that I've done is I take part in arguably too many PhD research projects, and I just help out wherever I can and answer questionnaires, or just give a patient perspective on panels. And probably the one that's made the most difference is I've proofread quite a few patient information booklets for Bone Cancer Research Trust, and also a small charity called Port. And I've also read some little kind of flashcards for dentists and GPs that they can have in the office, so that they know the symptoms of primary bone cancer, especially in young people, because it's quite common that, especially in young people, their pain is just fobbed off as growing pains. And so, that delays diagnosis for 2-3 years, and then it's too late. So my advocacy is kind of focused on informing patients, informing researchers, and just the general kind of academia in smaller charities.
And it's extremely valuable. And I was just sort of making a little note there, because your insights and the age you are, and now that you've straddled the sort of pediatric and moving into the adult world, having your input on age appropriate resources for people in circumstances similar to yours 8 years ago must be really, really important and extremely valuable, to pass that knowledge on and that information on. It's really a key role, isn't it?
Yeah, I think so. It's something that I'm very passionate to talk about, because a theme throughout my treatment was either, when it was convenient, I was treated like a child, and I was, you know, decisions were made for me, I wasn't involved, things just happened to me and I accepted them. Whereas when it was also convenient, I was treated like an adult, and there was kind of no in between, and that left me kind of confused as to what my position was in my own treatment. Did I have a say? Did I not have a say? And it was just all very confusing. And I'm a very big advocate for kind of addressing the right audience and giving information. You know, I've studied medical law. I know that you have to give certain information at certain times, but it's just the way that is given. I think that is extremely important, especially to young people, but to anyone. Like, you know, as Mike said, you get blown away as soon as you get a cancer diagnosis. So if you're bombarded with all this information, you've ticked the box, but it doesn't mean that you've done the job. So it's all about building that relationship between patient as a person and the doctor who's going to be with you throughout that whole journey.
Yeah, and again, that's another key aspect, isn't it? Because timeframes often aren't really the friend of the clinician, I suppose. You know, you don't often get as long as you'd like with those consultations, and similarly from a patient's perspective, you don't necessarily have all the questions ready for yourself in that moment, and then afterwards, you know, there's got to be that dialogue afterwards as well. Cleona, did you, just as a breast cancer surgeon and a breast cancer researcher, I guess, do you experience a span of different age groups in your work, and do you kind of look to engage with them in different ways?
I mean, absolutely. The youngest patients I would see would be in probably early to mid 20s, and they're very, very rare. And then you get, I mean, breast cancer is an age-related cancer. So the older you get, the increased risk of breast cancer. And I think it's one of the very important things is to not be ageist. Because, I mean, there are different issues for different age groups. Exactly as Imi says, there's fertility issues that need to be tackled up front in young women where you're potentially using chemotherapy or anti-estrogen therapies. But in terms of surgery, it's about fitness for surgery and about patient wishes and priorities, irrespective of age. And thankfully, there are tools that we can use to sort of, with your general health and your comorbidities, what are your risks of chemotherapy, of surgical complications, anesthetic risk, to help us have those conversations. But the key thing is, it's not about the date of birth. It's about the individual and their individual circumstances, and tailoring the treatment to them and their needs and where they are at their stage of life. I mean, just again, taking reconstruction as an example, if it's a young mother, she may not want reconstruction because she's too busy. She might want to save it for later when the kids are a bit older, and, you know, and tailoring the treatment to plan for that long term.
Absolutely. These are really valuable insights. So thank you for sharing from both angles. Actually, it's really interesting. You know, when we talk about health inequalities, we don't necessarily focus on young versus old. And actually, there's a whole bit of research there to be looked at. So maybe let's come to Mike with the same question. I guess for you, I know, have been involved as a really active participant in a lot of different projects and activities. So maybe you can give us a little bit of an insight into how you contribute.
Yeah, something you mentioned earlier with the targeted lung health checks. And I remember them coming into Manchester as a pilot with a project that had been set up by Macmillan, the Macmillan Cancer Improvement Partnership. And that was used as a vehicle to try that out. At the time, Manchester was divided into, the city of Manchester was divided into 3 CCGs. And I think, if I'm not mistaken, they were the highest, the 6th highest, and the 8th highest in the country for the incidence of lung cancer. So that was sort of like overseen by the steering group of the MSIP, as we called it. But what they did was they targeted clusters of 5 GP practices to run the pilots, 1 in each one, and they were the ones with the 5 highest incidence of lung cancer. And then it was all about engagement. Local radio stations, community radio stations, some of us at various times standing outside Asda's, advertising it and pushing it, and then the idea was to bring people in for these targeted lung health checks and diagnose it early. At the time, the data that we got was that it's something like 80% of people diagnosed with lung cancer were diagnosed at stages 3 and 4. And those are the most difficult to treat or not possible to treat. So when it was we'd started collecting the data, I actually got invited along to the media launch, and none of us, they kept it secret and none of us knew, and they completely reversed it. 80% were discovered at stages 1 and 2. Over 90% of the patients were offered curative treatment rather than sort of like palliative. It made an immense difference. And from that, although it's not necessarily directly involved, through working with NHS England, I'm now seeing that being rolled out nationally. And I mean, so like the difference that makes is just sort of like absolutely enormous. But going back to sort of like patient information and how it's used, one thing that I'm currently involved in is we're doing interviews for patients to go on a panel for something called CPES, which is the Cancer Patient Experience Survey, which collects information from patients who've gone through a cancer diagnosis and treatment to feed back to the trusts so that they're getting more information of people in real time as it's going through. But there are patients actually on the panel overseeing that, modifying the questions, and they've actually got a patient interviewing the patient to select them. So it's, I mean, we do sort of like take it to those lengths. As regards sort of like time with patients, that may, when you were talking about that, that reminded me of a quote from a patient I worked with a while ago, Mark Davis. And he always said that sometimes you need to remind the clinicians to concentrate on the fleshy bit around the tumour. Some of you might know that as the patient. So yeah, I mean, it's all that. And for Imi, when she was talking about mental health, we have just started with NHS England a massive programme on cancer and mental health, the impact of a cancer diagnosis on your mental health, and for inequalities and closing the care gap, getting better outcomes for people with mental health who get a cancer diagnosis, because that can be a barrier to getting the right treatment at the right time. So there are things going on, and with the patient voices in there, it's not just about adding the patient voice, it's also about accountability, in that, are you getting enough people through on time? If not, why not? We want to know why, you know. So yeah, there's plenty going on.
That's fantastic. That, I mean, you know, using humor sometimes can really kind of make things a little bit more relatable, can't it? That, I mean, that quote is just, that's gold dust quote. That it really makes you think. So okay, so bringing it back maybe to Cleona at that stage, who does deal with the fleshy bit around the tumour also, and just maybe if you've got some thoughts on how engaging with patients in your professional roles, you know, really helps you to change your practice and enables you to work, you know, more streamlinedly to sort of close that cancer care gap.
I suppose one of the research projects I've done recently was actually a piece of work with patients and the public to find out what their priorities were in breast cancer research, because there was a publication about 10 years ago where they got the 50 sort of leading breast cancer scientists to write about what they thought were the research gaps and the holes in knowledge with regard to breast cancer treatment. And then again, the Lancet commissioned another project of breast cancer surgeons, asking them what they thought the gaps were. And I'm mortified to say that neither had any patient or public input on those. So we had a list of surgeons' priorities and a list of scientists' priorities, but no one had actually asked what are the patient's priorities. And again, back to what you say about Imogen, about efficacy. So you can imagine that a lot of the scientist research priorities were either million of miles away from the patient. So how to improve the survival of a breast cancer cell under the microscope. Or it would be about how to get an extra, 2 weeks of survival with very low quality of life. Things like that, the real efficacy and survival, minimal marginal gains. But patients, it was very much about quality of life and about the pathway, getting results quickly, getting good communication, getting the, bells and whistles that are not bells and whistles, are the fundamentals of breast cancer care, like mental health support. And so they brought a whole other identified a whole other area of research that is required. And so that was really informative. The other thing I do is I work with breast cancer charities. So I work with Prevent Breast Cancer, a Manchester charity that's the only UK charity purely focused in breast cancer prevention. But when you work with a charity like that, you get to spend time with patients and family members when they're not actually sat in your clinic. And I think that's when you get a very different conversation. The conversation you have across the clinic desk, there's a reason for that interaction. And actually you need to have the informal interactions with patients to actually get the broader picture.
Absolutely.
Actually, and I think one of my, but just one of the things that really drove my interest in this was because my PhD was doing blood tests on patients when they were having chemotherapy. And it meant the only way I could get those blood tests at the times I needed was to drive out to patients' houses. And so the whole of my PhD was home visits on patients during chemotherapy. And wow, I learned so much in that. It was such an honoured position to be let into patients' homes and see them at their most vulnerable and talk to them about how tough it was at that time. And so it was a real eye-opener that has informed the whole of the rest of my career.
That's fantastic. It's great to hear that influence has been so strong for you as well, and that you can integrate that directly into your practice and how you train and teach others as well to have that perspective. I think it's massively important. I would say as well, a bit of a shameless plug probably, but we have a full unit on early detection in transformative oncology, and it's a real kind of steer from Manchester at the moment. It's a real priority. We've talked about lung, we've talked about other cancers, moving the detection into an earlier stage which is more treatable is absolutely the way that we're trying to funnel our research at the moment, and that requires people to have that awareness and to do that self-check and to to seek help if they see something just a little bit unusual about their own bodies. So all of that communication is really important. Imi, you said earlier about the growing pains masking some other maybe perhaps more sinister symptoms, and having giving patients confidence to recognize that in themselves is really key. So getting that communication out early, absolutely key. So I suppose, well, if you could, and you have, because we've got a captured audience, we've got a breast surgeon right here anyway, but if there are other pieces of advice, if you reflect on your own sort of experiences of coming through there, what would you challenge the health professionals or challenge the clinicians to do more of at this stage as you're working through, so you get that greater consideration for patients? I don't mind. Imi, do you want to go first?
Yeah, sure, I'll jump in. I have a feeling I'm just going to be almost repeating myself, but one of my largest pieces of advice would probably be just think about your audience and who you're talking to, because obviously I speak as someone who was treated very young. I can recall times where my parents would go into a room and I'd be left in the bed, and then I'd eventually find out the information about the next course of treatment that I had no idea, until I was on the plane to America to go and have proton treatment. I had no idea what was going on. And then there was a time where I had my surgery and the two surgeons went into very gross detail about what they were about to do, and it just overwhelmed me. And I think what was needed there was, hi Imi, you're about to go to sleep for you know, 8 hours, you'll wake up with a scar that looks a bit like an L shape. You'll be really groggy. You'll be in hospital about a week. You'll be stuffed full of needles, but that's okay. We'll look after you. Beautiful. Then tell my parents all the legal stuff you need to handle, because I didn't need to hear it. But what I did need to know was what was happening day to day in my treatment, because otherwise I was just not an active participant. And then that affected how I felt like I could influence my own decisions. And that ended up being kind of exemplified in a nurse came to give me some drugs, and I said to her, that's not my dose. I know that's not my dose. And she went, yes, it is. I've checked it. And I took the dose, and I was overdosed on my antidepressants for 48 hours.
Wow.
And so it's just that kind of perspective of yes, I was 13, but I know myself and I know my dose and you know, so it's just things like that, and the kind of a tendency for medical professionals to be a bit paternalistic and like, I know what's best for you, and so this is what we're going to do, instead of having that conversation. Kind of on that note, I think another piece of advice is to think holistically. So kind of think like past, present, future. And like, you know, Cleona said, it can be difficult in the kind of time constraints. Like if you're so focused on treating the tumor in, you know, first instance, you can, you know, other things can be neglected that might be really important to that patient. And as I'm sure Mike is probably going to pick up on in a minute, the late effects side of things is very much neglected. You know, I had no idea that I'd still be struggling 8 years down the line with things that happened to me, you know, 9 years ago. And that was something that I was not made aware of, nor my parents. Like, it can't be blamed on the fact that, you know, I just wasn't told as a kid. My parents had no idea either that I'd, you know, suffer, you know, kidney damage, that my fertility would go, that I'd have brain fog for the rest of my life. You know, just all these things that you then have to adapt for in later life that I had no idea until it was happening, you know. So I think in terms of how that relates to patient advocacy and closing the cancer care gap, I think the kind of sole advice is remember that patients are humans. It's like what Mike said, you know, we're not just the tumor that you're treating, and involving patients isn't just like a political exercise. It's not just ticking a box to say, yeah, we've got their consent and we've got their input. It's actually having that interaction, having that understanding of what their needs are, and not just, you know, solving the problem. It isn't just a matter of solutions. It has to be tailored. You know, again, easier said than done. You know, I'm not blind to the fact that in a clinic it's not that easy, but I think, yeah, generally it just needs to be a whole, like a holistic look at what that patient's needs are and how they want them solved.
Emma, your words are so powerful, and I'm just going to invite people, if there's anyone in the Zoom room, really wants to ask any questions directly to these incredible people who are sitting on this panel with me today, who are being very generous in sharing their experiences and their understanding. I think there's an awful lot to learn, and I think the reciprocal learning aspect of this is probably one of the most important parts. Thank you, Emmy. So Mike, yeah, so I know that you've got quite a nice story of realization when it comes to late effects and starting to think beyond where you were at a certain point during your treatment. Would you like to share?
Yeah, I mean, a cancer diagnosis, never tell anyone they've got a good cancer or an easily survivable cancer. The only word you hear at the time of your diagnosis is cancer. And at that point, whatever they're trying to tell you, you are trying to process the fact that you are now a cancer patient, whether you've got symptoms or not. In my case, I didn't even have symptoms. But just hearing that one word changes your life. You never look at things again the same way. And I was diagnosed in February of 2014 and started hormone therapy to shrink the tumour. And then I had a month in July. The entire month of July was radiotherapy every weekday for a month. And halfway through that, I called into the information centre and was looking through and picked up a booklet on the late effects of pelvic radiotherapy for men. And that was the first time since February I'd actually looked beyond the treatment, what's going to happen in the future, what could happen in the future. And it's, at the time, you don't even realize that you're doing it, but it's later you look, you think, yeah, that's when I sort of like, I tuned into sort of like being a cancer patient as such, rather than sort of like, I just don't know what's going to happen tomorrow, because you live your life and you don't think about sort of like how far into the future. The future is just the future. Once you become a cancer patient, it's tomorrow. I'm not looking past that. You know, you're looking at things on TV and you're thinking, this is on for a month, will I get to the end? You know, it's you really don't sort of like know where you're going to go with it. And then gradually you sort of like, well, there is hope. And as it happened in that particular booklet, there was a flyer for a support group. And eventually when I finished treatment, I rang them up and I spoke to a guy called Brian, and he told me, and he was right, which is a very rare thing. I told him what I'd had treatment wise and everything. And he said to me, well, Mike, I can tell you, I've had exactly the same prostate cancer as you, the same diagnosis, the same stage, which was stage 3, the same treatment, which was hormone therapy and radiotherapy. He said, and that was 12 years ago. And I thought, wow, this could be me in 12 years' time. So it's, you sort of like, all of a sudden you realize that sort of like these things can sort of like, there is a difference. But if you look at a word cloud on patient events and ask them what it's about, you just get bewildering, scary, terrifying, confusing. Particularly at the early stage of a cancer diagnosis, you have not a clue what's going on. And in my case, sort of like the day that I was told it, they gave me a big bundle of booklets, loads and loads of useful information in there. I call that my welcome to cancer pack. And I think most people just bin it as soon as they get outside the hospital. You really can't process it. And when we got to talk about communication, an awful lot of people will tell you that, oh, well, we did tell you that. It was in that booklet that I gave you. You need people to lead you through these conversations. And I think a lot of the time, it's not just the clinician directly, it's the CNS, the clinical nurse specialist. They tend to have a bit more time. And it's sort of like, explain it to you one piece at a time as they give it, and have that conversation more than once, because even the first time it might not sink in, and then you got to revisit it. So there's an awful lot around the communication side of things to work on.
Yeah. I completely agree. Thank you so much for sharing that with us. It's a really important aspect, and another strand to this is understanding just how many different job roles, just how many different multidisciplinary areas there are, just how, and how long the period of time is. When you talk about cancer, you don't just talk about a clinician and a patient, but a whole plethora of other job roles and expertise that and building this sort of living with cancer is another theme of research, I think, which is quite strong in Greater Manchester Cancer, actually, because it's, we're starting to understand that part is absolutely as important as anything else. James, I'm going to jump back to you. Oh, sorry, Imi, you've got very politely put your hand up.
I did just want to jump in, but I just thought I wanted to add to that and say, just as Mike said, it's like, we're going to focus on the treatment and we're going to go through it. We've got the information, and it's so bewildering. And I think people forget that, once you've had that clear scan and like, fantastic, see you next year. What? But that's it. Like, that's it. It's just like, people have described it as just being dumped off a cliff. It's as bewildering and terrifying to go beyond cancer as it is to be diagnosed with it, because you get diagnosed and it's like, oh, this is terrifying. And then I would argue you get quite used to it and you feel quite comfortable in it, because especially for me, I'd go in for my treatment and I'll be like, cool, I'm actively doing something that's kind of keeping me a bit safe. And then, for me, it went to like scans every 3 months, then every 6 months, then every year. And now I just have nothing. I have no idea how I'm doing at all, And so in terms of, post-treatment as well, there's got to be more steps for holding your hand through that as well, because, again, a leaflet's not going to do it. It's not just focusing on the prevention and the treatment at the initial time, it's also that kind of, late effects is one thing, but it's just also the whole experience of moving past cancer and trying to find that identity beyond it, that, you know, we need guidance on.
That's so powerful and so honest, and thank you so much for bringing that to this conversation, because it's really important. I know that everybody listening will have been touched by what you were just saying there. James,
Yeah.
I think we might have some audience questions, possibly.
Yeah, we do have a few. Yeah, thank you very much for sharing that. That's great. So we've got a question from Sarah on LinkedIn, who says, how should respect for patient experience and voice be trained into practice throughout clinical training of, for example, doctors and nurses? So perhaps we get maybe a view from Professor Kerwin on that, perhaps.
I think it has to be right from the beginning. It has to be woven into all of your clinical training, the importance of communication, the importance of opinion, patients' values, you know, that, well, Imi referred to paternalistic, and certainly that always was how it used to be. Hopefully it's improving, but it's never going to be perfect. And unfortunately, clinicians are humans as well, and you're going to get a spectrum of personalities and a spectrum of abilities to have communication skills, but all we can do is try and be the best that we can be. So it's got to be training right from the beginning, working with patients, having 360 feedback, so you get feedback from patients and reflect on yourselves. It's certainly within Manchester Medical School, there's a lot of training on personal reflection, so that you think about how you're doing, and it's a recognition that we are inadequate at it, and we've got to keep trying to improve and look at the whole journey, including living with and beyond cancer.
Yeah, thank you very much for that. I think that's very much the case in this situation. So one last thing we're going to look at in this webinar is ways in which you can study at the University of Manchester in this field to learn more about oncology. So one program that we offer is Transformative Oncology, and part of that program, one of the units focuses in on this idea of creating the best care possible for patients. So I'll hand over to Susan and Cleona to maybe introduce some of the things that are touched on in the program and in that particular unit. I believe it's Unit 8 in the program.
Yeah, thanks, James. It's Unit 8 of our program, and in some ways it's the most important. So the patient-centered aspect of that particular unit is so important. And as we've discussed really just during this webinar, it's not just about the oncologist, the clinician and the patient, but it's about all those other associated job roles. Transformative oncology was designed to appeal to anyone who wants to work and really push the boundaries of improving healthcare outcomes for patients with cancer in a multitude of different job roles. And you know, the final unit is delivering the best patient cancer care, and it's about understanding the patient's perspective and building in that time to listen and reflect on our own learning, building in that reciprocal understanding from both angles, looking at treatment planning. Absolutely, just as we've discussed before, you know, it's really important to think about the impact of that treatment, what the options are, how it impacts on the, you know, the quality of life. Hugely important. It depends on the individual and how active or how old or how, you know, whatever they want out of their life moving forwards. And also that, you know, a big focus on that multidisciplinary approach and why it's important to have all those different healthcare professionals involved in the conversations around an individual patient. And I'm delighted to have Cleona here, who's the unit lead for this unit, and you know, we're working together at the moment with cancer nurses and different professions to really build this unit. Cleona, did you want to add something?
I just think the title of this unit is Establishing an Efficient and Effective Clinical Pathway to Deliver Optimal Results. And I think that's key. What is effective? And that is what is giving the best for that patient, the patient getting the best outcome. Optimal is about what the patient wants. And so, you know, the first part of this is understanding the patient's perspectives. So we're nothing if we don't understand what the patient wants, what they want out of their treatment and out of the rest of their life. And they may not even know what they want. And so, you know, increasing our understanding and learning in this program about how to help the patient work out what they want. Because I think Mike effectively said, you're told you've got cancer and you go deaf. You now cannot make any more decisions. You cannot understand what's been offered to you because you've gone deaf. And we as clinicians have to say, you know, this is the pros and cons. And actually, not just for tomorrow and next week, but for 20 years' time. You know, the number of breast cancer patients that said to me, oh, just cut it out. Doesn't matter. Take what you need to. The scar can go anywhere. I don't care. I don't care. Just get it out of me. That might be what they want in the next month. But in 20 years' time, they might regret that. And so understanding truly what is meant by the patient's perspective, short and long term, and individualizing that to the rainbow of humanity and geography and socio-economic circumstances, as well as personal priorities. And then I think treatment planning is a very important one, because that has to be, again, tailored to the patient, but also with the patient having an understanding of how all treatments interact. Surgery interacts on ability to deliver chemotherapy or deliver radiotherapy. Some drug treatments interact with other drug treatments, and they may have different side effects and outcomes. So getting a better understanding of that and how it might apply to an individual patient who has different religious beliefs, or, you know, someone who can't easily get to a radiotherapy centre because of travel or financial issues, or needs to go to work or has had childcare issues. So treatment planning around the patient. And then we've already said about multidisciplinary approach. And it was quite interesting, even in discussing this unit. And I, obviously, you've heard my bias to breast cancer because that's my area of expertise. So multidisciplinary to me, knee-jerk, is radiotherapists, chemotherapy doctors, surgeons, pathologists, radiographers, radiologists. And then we had someone else saying, but actually in ours, it's about much more mental health, occupational health, physiotherapy, other allied professionals, but actually they're all relevant to all cancers. And so when we think about the multidisciplinary approach, we need to have an understanding of all of that. So I think it's an exciting project that I'm really looking forward to pulling people together to help with.
Absolutely. Yeah, thank you very much for that. It's a really exciting program. And if you would like to learn more about the program or get involved and even enroll, you can feel free to contact me. So just a little bit of information about the program. I'll just share my screen here. So yeah, the Transformative Oncology program is a fully online program which you can study part-time. We have MSc or PG Cert or PG Dip options, and depending on that, it will take between about 1 and 3 years to complete the program, with about 15 hours of work per week. Our next enrollment is in September. So if you would like to know more about this program, you can visit the website there that's linked, or you can email me, studyonline@manchester.ac.uk, and I'll be able to answer any questions you have about the program. I'm just going to run a quick poll for all our attendees, and feel free to answer those 2 quick questions. There is a few questions in the Q&A that we haven't got round to answering today, but I will get back to you with an answer by email. So just look out for that. And also we'll make this recording available to all our attendees as well. So yeah, the Transformative Oncology program is available at that website. You can learn more about that or email in as well. And that pretty much concludes our webinar today. So a big thank you to all our panelists for their time and their insights, which I think will be really valuable for everyone who attended today. I think people have learned a lot there. I know I certainly did. So thank you very much for all of that. And thank you everyone else for joining. And yeah, feel free to get in touch about the program, and we'll speak soon.
Thanks, everybody. Thank you.